Good afternoon, everyone, and welcome to the Maternal Health Echo, which is brought to you by the Center for Substance Use Training and Telementoring Center, or CSTAT, at Be Well, Texas, in collaboration with the Perinatal Psychiatry Access Network, or PeriPAN. My name is Brenda Macias, and I'm facilitating our Echo session today. Once again, to help us with attendance, please type your name, affiliation, and email into the chat. We hope you'll join us by video for the discussion portion in the latter half of the session. But no matter how you're joining us today, we're just happy you're here to learn alongside us. We encourage everyone to unmute and share questions and comments aloud after the didactic, but we ask that you stay muted unless you're speaking. There are a lot of us in this space, so keeping your comments brief will allow others the chance to share as well. And finally, note that no protected health information is allowed in either the chat or in our discussion today. Our didactic is on suicide prevention interventions for women and will be presented by Dr. Jasmine Stevens, an assistant professor in the Department of Psychiatry at UT Southwestern Medical Center. Following that, we'll have a case presented by Dr. Joshua Kern. And so now we'll start with introductions. We'll follow by the didactic, announcements, the case presentation, and then finish up with an open discussion. Thanks again for joining us today. And so I'd like to introduce our Hub team members. First, Dr. Emily Humphrey.
Good afternoon, everyone. My name is Emily Humphrey. I'm a DNP in Waco, Texas, and I've been working in addiction medicine for about 12 years and worked on the inpatient and outpatient side and with women that are pregnant and not pregnant. So,
Thank you, Dr. Humphrey. Dr. Joy Subrin.
Hi, good morning, everybody. My name is Joy Subrin. I'm a licensed master of social work and a doctor in behavioral health. I have been working in the outpatient setting in an OBGYN practice with pregnant and non-pregnant women, managing opioid use disorder and other substance-related disorders. And it is just by far the most rewarding part of my job to see people change their lives. So I'm so happy to be here today and share some thoughts and ideas about this case.
Thank you, Dr. Subrin. Dr. Anastasia Ruiz.
Hi, everyone. I'm a psychiatrist physician, and I am part of the faculty with TTU HSC in Lubbock, Texas. I'm also the regional program director for the PeriPAN program, and I'm so excited to be here to talk to you guys about this such an
Maybe I can put this on.
Thank you for joining us today.
Thank you, Dr. Alag. Dr. Ruiz. Dr. Porvanchi Alag, our next one.
Awesome. Thanks. It's nice to be here with all of you. I'm also one of the faculty at Texas Tech University Health Sciences Center in Lubbock, Texas. I happen to be an addiction-trained psychiatrist and also an obesity medicine specialist. I work very closely with individuals who have substance use, mental health, of course, and then I also try and do a little bit of obesity medicine, kind of a holistic approach. I'm passionate to work with the adult general population and females, or pregnant women population, non-pregnant women population. I'm trying to work with adolescent as well, but we'll get there someday at some point. But I'm excited to be here and learn with you all.
Thank you, Dr. Alag, and I want to welcome all of our Hub team members and thank all of you for participating in today's session. And with that, I'll turn it over to our presenter, Dr. Jasmine Stevens. Dr. Stevens, we're glad to have you here, and we'll now hand this presentation over to you.
Thank you. Thank you. Perfect. Thank you. Well, as she said, I'm Dr. Jasmine Stevens. I'm a psychiatrist at UT Southwestern, specializing in women's reproductive mental health. And today I'll be giving the maternal health echo on reducing mortality from suicide and overdose in the perinatal period. Next slide, please. Where does it go? Okay, perfect. Okay. So for disclosures, Essentially, we all have no disclosures. All members and speakers of the planning committee have no relevant financial relationships with commercial interests to disclose. The views expressed here throughout the talk that you will hear do not necessarily reflect the official policies of UT Health, San Antonio, Texas Tech Health Sciences Center, the Department of Health and Human Services, or Texas Health and Human Services. Nor does the mention of any trade names, commercial practices, or organizations imply endorsement by the US or Texas government. Next slide, please. And though we have stepped into October, September is National Suicide Prevention Awareness Month, so the alignment of this is very timely. Yeah. Next slide. So for my learning objectives, here's some things that I hope you all would be able to take away from my talk today. I want you to be able to apply evidence-based screening tools to accurately identify and assess for suicide and substance use disorders in pregnant and postpartum women. I hope you'll be able to implement some evidence-based responses to positive suicide or substance use screens and to be able to develop skills to improve care coordination to support positive maternal and infant health outcomes. Next slide. So to begin with, let's think about the importance of screening for suicidal ideation. We know that suicide and overdose are leading causes of death for Texas women in the first year postpartum. With thinking about some specific numbers, approximately 23% of pregnancy-related deaths are from suicide or overdose. 67% of these individuals had a current or past substance use disorder, and 63% of those deaths occurred from anywhere from day 43 to day 365 postpartum. 72% of mental health related deaths involved a history of depression, and overall, these deaths were preventable. Next slide. With thinking about the causes of pregnancy-related deaths in the US, the data is evolving and the proportion of deaths related to suicide and drug overdoses has increased in the recent years. If we think of all four of these categories, drug overdose, suicide, homicide, and then also kind of some of the ones that's in this other kind of component with indirect causes and direct pregnancy-related complications, we can see some trends. Focusing on pregnancy-related deaths from drug overdose, from 2010 to 2019, that accounted for 11.4% of those deaths. But specifically from 2018 to 2022, in a shorter period of time, that was an account for 19.4% of those deaths. Similar thing happened when it comes to suicide. We're looking at it overall from 2010 to 2019, that accounted for 5.4% of pregnancy-related deaths. But from 2017 to 2019, there was an increase of 8.4%. So we can see that like overall, there's been some increase in the more recent years. And this could also account for the fact that over time, more states are including some of this data to help it to become more standardized and reportable on a national level. Next slide, please. So if we know that untreated or undertreated psychiatric symptoms lead to worse maternal fetal outcomes, especially with the interface of these two psychiatric considerations, suicidal ideation and substance use at play, then applying early intervention and screening offers a chance to mitigate such risk factors to be able to lead to healthier outcomes early on. We know that being pregnant or being postpartum does not necessarily protect against mental health issues. We also come to understand that talking with non-psychiatric providers about psychiatric symptoms helps reduce the stigma. Their guard is a little bit lessened and more down whenever they're talking to someone who's not an official mental health representative. Asking about suicide reduces risks. It does not plant the idea of suicidal ideation there for them. Also, screening for suicide risk and substance use provides an opportunity for enhanced safety planning, and overall, evidence-based practices like screening and having follow-up will improve outcomes for parents and children. Next slide. With thinking about stratifying some of these risk factors, I know this slide may appear busy, but I'll kind of walk you through what I want you to be able to take from this, or what the point we're trying to highlight here. We can see that suicide and substances are at risks at various stages. So whether it is a predisposing factor, that being components that have occurred historically, suicide pops up there, whether they've had prior suicide attempts, trauma history, family history of some of these things, and even accidental overdoses is applicable here. Having a history of some type of substance use disorder, low opioid tolerance. And then even if we think about precipitating factors or the specific events that's contributing to this direct outcome, suicide plays a part with this, with whether they are acutely in a psychiatric crisis or if they've had a birth trauma or perinatal loss. And similarly for accidental overdose, was there a recent relapse or increased substance use? Is there polysubstance use? And this can even be at play for perpetuating factors. What's keeping this going on? So whether that's persistent suicidal ideation or having the social isolation and hopelessness, or even ongoing substance use or misuse. So it can be important at different stages, kind of highlighting where these risks can occur. Next slide, please. Here, I want to highlight how you're likely already screening for suicidal ideation in patients. And we'll kind of highlight and walk you through the different ways that this is probably already happening or where you can incorporate this. And here are a few screening questionnaires that's used in some different clinical settings that will achieve this. Go to the next slide. So directly for the PHQ-9, item 9 gets to that. This says thoughts that you would be better off dead or of hurting yourself in some way. For the Edinburgh Postnatal Depression Scale, or the EPDS, something that's commonly used in obstetrical settings, item 10, the thought of harming myself has occurred to me. That aims to inquire about suicidal ideation. It would be worthwhile to ask some follow-up questions like intent, plan, or desire to act upon it. And then there's also the Columbia Suicide Severity Rating Scale, or the CSSRS. This is often used in the ER or inpatient setting, and this is really geared towards a more comprehensive review of suicidal ideation. There's some other measures that we're probably all naturally using, like the review of systems, or ROS, that's probably universally at play in all of our clinical settings, that has the psychiatric portion that screens for suicidal ideation. Maybe you're not using PHQ-9 or EPDS, but you're using PHQ-2. That also gets to this aim. And even at our clinic, an additional one that we incorporate is the Chart 7, and that goes into some more kind of comprehensive review around safety assessments. Yeah. Next slide. There are some validated measures used to screen for suicide and substance use. On the previous slides, we detailed things like PHQ-9, CSSRS for a suicide screening. There is also the ASQ, or Ask Suicide Screening Questions, which focuses on current or past suicidal thoughts, plans, intents, or even attempts. When it comes to substance use, there is the 4Ps and the substance use risk profile in pregnancy, or SIRP-P. Now, the 4Ps has been directly studied in the perinatal population, which is really important, and has a sensitivity of 90.2%. The components of this includes your parents. Did either of your parents have a problem with alcohol or drug use? Partner, does your partner have a problem with alcohol or drug use? Past, have you ever drunk alcohol or used drugs in pregnancy or present? In the month before you knew you were pregnant, how much did you use substances such as cigarettes, alcohol, marijuana, etc.? Now, the SIRP-P, this is also a validated 3-item scale used to identify the level of risk in pregnant women. It has a very high sensitivity as well, 92.4%, really important. And the things that it will get to is, have you ever smoked marijuana? And the month before you knew you were pregnant, how many beers or how much wine or how much liquor did you contain or obtain? Have you ever believed you needed to cut down on your drug or alcohol use? So these are just some natural things that you could probably incorporate into your visits with patients. Next slide, please. So if they screen positive, then what? This is where you go into all of the details of how to assess further, including what to document, maybe even who to document. Like, are you the best person to do this? Could this be something that another person on the team could do? Is this possibly already, is this information that we've already gathered from the chart or from another setting where the patient was seen? So we want to review these results supportively using person-centered, non-stigmatizing language. We want to be sure to assess for substance use patterns and co-occurring mental health conditions. We want to be sure to educate on substance-related maternal and fetal risks tailored to the substance. Information that you probably already know and that you have at your access and probably already giving them. Want to be able to provide brief interventions. This is within our motivational interviewing model and stratify that risk, whether low, moderate, or high. And for opioid use disorders, we recommend medication-assisted treatment like buprenorphine methadone combo and coordinate care. Of course, it's important to address mental health needs and discuss local reporting laws and legal implications transparently. So this may be important for you to brush up on your knowledge around that to know what is expected in that domain. But overall, the goal is to minimize harm, reduce stigma, ensure multidisciplinary support, and make sure that we can have some pretty good follow-up. Next slide, please. So if positive for suicide rather, now what? Here we will put it all together. For the safety assessment or the portion where you will go into further detail with patient if they say yes to being suicidal, here are some things that you may want to know. Has there ever been a past history of any kind of suicidal behavior or self-injury? Are there any current ongoing stressors for patients? Again, substance use. What do we know about this? How active is this? Is there access to weapons and is there a willingness to remove? Where are they with their readiness to accept care and to engage in safety planning and even to be able to arrange a follow-up visit? These are all things that's important for us to be able to understand if someone does screen positively. Next slide, please. To help with this, PerryPan has developed a safety assessment and planning tool for this step. The patient resource packet has wellness tools to guide with safety plan, self-care, action plan, and resources. And this can be, and you can access this in English and in Spanish at the link here below. Next slide. And here, the safety plan component is highlighted further. This is again within this resource that PerryPan has provided. And we really want to focus on getting this information in the patient's own words, understanding what they view their warning signs or triggers to be, understanding what they find their coping strategies to be, who's the best social contacts or supports for them, understanding the emergency contacts, and even other ways that we collaboratively can reduce access to lethal means. This is a time where this really should be personalized. It should be developed collaboratively. We really want to make sure that this is developmentally, culturally, and linguistically appropriate, and to be sure to include specific activities and people to contact. Next slide. Here are my references, and one more slide, please. And I thank you all for your time, and I hope that this brief talk was valuable, and thank you for having me here today.
Thank you, Dr. Stevens. And now I'd like to open up or offer our participants the opportunity to ask any questions that anyone may have. But yes, I see Dr. Luckner with his hand raised.
Thank you for this talk. It's very helpful. I have a question on sort of the adapting this type of screening to people who are older adults. I realize that's not really the focus of today's talk because older adults generally don't get pregnant, but with respect to, but it can be seen in pregnant women too, is there is a culture, particularly here in the rural areas, where the treatment for mental health is suck it up, buttercup. If you have a problem and you can't sort of pull yourself up by the bootstrap, then there's something wrong with you, as in like you're a bad person or you're just an incapable person. So what I find is that in this demographic, the PHQ scores will be 0, or maybe there'll be something about sometimes I have trouble sleeping. Similarly with the GED or any other screening tool of this flavor. Are there screening tools for people who are part of this culture where it is sort of a suck it up buttercup kind of culture there? If you feel depressed, then you just need to snap out of it, pray about it, and move on.
That is a really good question. I really appreciate you bringing that up because we should be thoughtful about different populations for individuals in that domain. I'm not recalling a specific one that's tailored to rural populations, but I will say that is a time where in the visit, whereas I'm listening to them talk about things, and if I kind of understand this person's disposition to maybe minimize symptoms more, I'm probably going to ask them more like, I see that you said this here in the questionnaire. I just want to know more about that and, ask this thing in different ways. Too. That's also where some of the other kind of questionnaires, like the Columbia suicide rating scale, that goes into a more comprehensive review, can be helpful. And also the Chart 7. I think that's also one that does a really good job at asking some of these questions in some different ways. Like, have you ever felt like you just could not do anything correct, or you were doing everything wrong, or there was no one that you could turn to? And so using some of these other questionnaires or scales that ask some of these questions in some different ways. I don't know if anyone else in the audience is familiar with any other scales too.
I was curious if there was an isolation scale. I also appreciate the question because my population is GYN as well, all the way into 100 years old and over if they are coming in for care, and that's oftentimes what I see is depression in conjunction with loneliness. So I'm not an expert at all scales, but I wonder if there was a loneliness scale. Sorry, I cut someone off who had their hand raised. But I think it's a really wise perspective to think about our older adults and these screening tools.
Thank you, Dr. Subrin. We have another hand raised from Sharon Jella.
Sorry, I was trying to figure out how to unmute. So I have a question. This would be more prenatal care. So say, for instance, if they do have comorbid depression, anxiety, and, first line therapy, you want to do like citalopram, maybe fluoxetine. But if they also have cigarette smoking, do you know if there's any evidence about like started with bupropion to be able to treat kind of both at the same time versus just one? Any evidence or any knowledge that you have about that?
Yeah, I think that's a really great question. A lot of times when I'm at that type of place to where there's a couple of different options for what we could consider, if I'm like, these medicines cover depression and anxiety, or SSRIs, but bupropion can cover depression and helping us to cut back on cigarette smoking. That's also an option. I'd bring patient into that type of discussion, start to hear from them. You may start to glean from them if they are feeling like, the cigarette smoking is really secondary to the anxiety. I imagine if the anxiety gets better, I probably will cut back on that. Let's focus on this one thing. Or no, I really feel like I'm so down and depressed. It's hard for me to cut back on this. If I've struggled with this in other ways, I really want to go with this one. So that's usually a time where I will bring patient in with that point, with understanding which one of these methods could be best, because I think either of them is really valid. Yeah.
And one follow-up question with that. So like those usually that we start for, let's say, for instance, if it was the cigarette smoking, right? So like 150, would you ever go any higher than that for Wellbutrin bupropion? Then that, I know for the regular population is like 150 BID, but I do worry because of the, information that they have about Wellbutrin does crosses the placenta. So what is usually the dose that you will use if you needed to use those two in combination?
So the highest dose of bupropion that I've used is 450, and I also think that overall FDA regulations speaks against going to 600 or above because that's where we've seen the risks of seizures happening in those studies. So usually 450 is probably the highest that one will use. And if you are thinking of wanting to use one that's twice a day dosing, maybe like the SR version of it, the one that comes in like 100 milligram increments, with maybe one that's better tailored towards that too, if you're finding that you're kind of limited in some ways and you're wanting to have something that's a dual dose scheduling.
And you're talking about that would be for pregnancy as well, right? So,
Yeah, because you really want to think about optimal dosing
right.
for individuals if you're going to use such a medication. Yeah.
Thank you very much. I appreciate it.
Yeah, absolutely. Good question.
Thank you for your question, Sharon. And it sounds like if you have a specific patient in mind, that would be a great case consultation form. So I think maybe somebody from our IT team can reach out to you and share that link directly with you so you can bring it to the ECHO community. We had another question in the chat that was posed by Jacqueline, which Dr. Ruiz has already addressed in the chat. But Jacqueline, if you need additional information about the percentage of women with postpartum depression who go on to attempt suicide, please unmute your mic and let us know. We had another question in the chat from Alejandra Mora and want to give her the chance to unmute her mic and ask that question aloud. Actually, she doesn't have a microphone available. So Dr. Alag may have answered this question already. Is there any research that speaks to the... Oh, go ahead. Yes.
Can you hear me?
Yes, I can.
There we go. So my question was in regard to like the number of times the assessments are done by patients. Is there any research to say that if they complete a certain number of assessments, so I gave an example as if they were to complete 8 assessments within a short period of time, is there a trend in which their score changes? So would they be more likely to score higher or lower in comparison to somebody who would have only been given an assessment within that same time period of say like three times versus. So I guess it's not so much the cadence in which assessments are done, but more the number of assessments. And I say this in the light of there's a lot of interest. So it looks like there are multiple units that are interested in assessing moms. Using the Edinburgh scale. So would that be a detriment where you have the provider and then you would have somebody like in the NICU maybe doing a project where it ended up invalidating the results?
And I'll allow Dr. Alag to answer. It sounds like, is that what you were saying, Brenda, that Dr. Alag was addressing that question?
It looks like she's dropped a few scales in there, some 20 items short forms. Dr. Alag, do you want to elaborate on that?
Sure. I wanted to first answer the question I just heard before we can talk about the UCLA loneliness scale. I haven't personally done this, but I've heard about this scale. But I guess to answer, kind of circle back, I just had this question. It's a very interesting question you just posed about I'm hoping I'm understanding the question correctly. The number of surveys that we give out, is that right? Does that impact the
Yes.
scores?
So it's easier if I guess in a there's a mom who's given the survey, let's say the Edinburgh scale, within a 45-day period, 8 times by different people versus another mom that's only given 3 times. Is there a difference in a trend of their scores?
I honestly, this question actually was brought up to my attention by one of the medical students. It's a very interesting question you did pose. And we ended up looking up. It wasn't specifically for moms, but it was just for general population, like the number of surveys we throw out to our patients, right? And I would personally have gone into appointments and have been handed over all these paperwork. So I'm like, well, this is insane. Like I'm here to see a provider and I'm going to be handed over all these paperwork and I'm not really engaged when I'm doing that. So what it comes out is what we found out is there's something on a survey fatigue, there's lower engagement, and the responses are usually shorter or they're also less thoughtful, the responses, right? Like I'm just going to do it and get done with. Some people will mark all the answers as 3, like the highest rating. And when you see them in the appointment, every single thing you ask them and their affect is so different. So I do think it impacts them a whole lot. So I would think that there's a response bias, or there's a higher missing data, or, I mean, I guess that's what I would think. Does that help at all?
It does. Though that helps because that's what I would think of in terms of fatigue or I'm done filling this out. I just don't want to answer it anymore, so I'm going to make it look a little bit better. So, yeah, thank you.
Yeah, and that's such a good question because I remember I was about to give birth to one of my child, and every single person had asked me the same question, what's your allergies? And I just remember I have no clue who I told or not. Like I, at this point, don't know because everyone's asking me the same question. I don't know what I told you or not. So there is a risk there. I did do a little search here, and I used Open Evidence AI, which is a free AI tool for any healthcare professionals, by the way. Um, and then pulls journals from MedHub and New England Journal of Medicine and all the available researches. It's like an AI tool that pulls all that information. And I just asked that same question. And it says there's no direct research to answer that question at this time. But there is research that says that repeated screening can help distinguish if someone's symptom is transient or persistent. So it's like a good snapshot over time. But I don't, you're right with the fatigue stuff. That's something else that we may have to address. Um, however, I think if a mother is really needing help, in my experience, if someone is really having mental health symptoms, the more they're getting the survey, the more opportunity to catch it. And so if someone is not symptomatic, they may have fatigue. They might say, oh, I already answered this and all fine. But if we can increase the screening and someone is maybe having a bad day, and maybe that bad day, they saw the survey and it was a window of opportunity, that's actually a lot of how our patients are referred to us, that we just give them the survey at the right time, at the right moment. And actually, I did a human trafficking course for medical students, and that was something that, if we can carry over that research, that was something that they found is that no matter how many times you counsel the patient, if you suspect someone is being trafficked or in a domestically dangerous situation, it doesn't matter. You do the same training, the same education every time because you just never know. Maybe that's the day that they are going to ask for help. So I actually just kind of my intuition without clear research to back it. My intuition is that we don't want to decrease screening. We want to just keep handing it out. And if someone doesn't want to do it, we respect that, but that they're expected to be screened at the appropriate time frames.
Thank you. Very insightful. Thank you to both of you.
Thank you, Dr. Stevens, and thank you, Alejandra, for your question. Just to protect everyone's time today, we're going to move on to our case presentation. However, I encourage all of our participants to continue to drop your questions in the chat. Our hub team members and our presenter will look over those and answer them as they can. And so now we move on to our case presentation, and we welcome Dr. Joshua Kern to walk us through the case. Dr. Kern.
All right, now I'm unmuted. Hi, I'm Josh Kern. I'm a emergency medicine physician at UT Southwestern, and I'm also a board certified in addiction medicine. We're part of a perinatal intervention team, and so we primarily see pregnant women and immediately postpartum while in the hospital, and we work in coordination with the maternal fetal medicine team. So this is one of our cases from over the summer. It's a 36-year-old Caucasian female. She's a G5P2. She's got co-occurring opioid use disorder, sedative hypnotic use disorder, possibly new seizures versus old seizures, and like possibly bipolar disorder, generalized anxiety disorder. She has a known history of depression, possibly bipolar disorder, and an anxiety disorder. Unknown if she's ever had any suicide attempts. She initially presented with from another facility. She was, I can go through the history here. She does have a history of trauma Also, recently, her fiance actually died of an overdose, and so that was impacting her care some. Doesn't use any stimulants. She started smoking cigarettes at age 16. Smoked about a pack a day until about 2 months prior to presentation. Um, Occasionally uses alcohol, about 1 to 3 standard drinks per week. Denies MDMA, cannabis. Started using IV heroin at age 26, was using 4 to 5 grams a day, and then started using fentanyl about 3 years ago, and has been smoking about 4 grams of powder fentanyl a day. Has been using alprazolam since age 16, so for about 20 years, pretty much almost daily, about 4 bars a day, 8 milligrams. These were not prescribed. And then no other hallucinogens or inhalants or anything like that. So primary SUD diagnosis, opioid use disorder, severe, sedative hypnotic use disorder, severe, a major depressive disorder, recurrent, and possibly bipolar disorder, moderate. She had a psychiatric consultation. I'm not a psychiatrist. So, and so in the past, she's been to Nexus, which is a women's rehab in Mesquite, Texas. And so she's had behavioral therapies there as well as during her hospitalization at our facility. In the past, she was on buprenorphine. Until about April, she was on a total of, I think, 28 milligrams divided over 3 times a day from somewhere else. And then what happened during this stay was she was at another facility, and then they gave her buprenorphine, and she had a seizure, which she thought was likely from precipitated withdrawal, and was transferred to our facility for that. And then so she didn't want to be on buprenorphine anymore because of that, of what she perceived to be a precipitated withdrawal seizure. And so she was started on methadone. She was started at a low dose, and she was in the hospital for a couple months, titrated up to about 240 milligrams. Initially, she was on BID dosing. She was transitioned to single day dosing, but she had persistent withdrawal symptoms despite being on 240 milligrams of methadone. Her QT then prolonged, and the OB team was concerned, so they decreased her methadone slightly, maybe 10 or 15 milligrams. She's been inpatient at Nexus before, and then currently hospitalized for 2 months. She was hospitalized, I think, back in 2018 for initiation of MAT. She has gone to NA before, but not currently attending. And so we offered her naloxone inpatient rehabilitation at Nexus. We gave her overdose prevention strategies and education on substance use disorder, as well as like neonatal opioid withdrawal syndrome. And we offered housing. She had nothing on her PDMP to review. And so her medications, these were all started while in the hospital. Methadone, 240 milligrams, quetiapine, 100 milligrams QHS, and then Keppra, 1,000 milligrams BID for seizure disorder. She was also on she was on CWA initially, and had scheduled Valium as well as PRN Ativan that was ordered as well, and was titrated off of the benzos while in house. Breast augmentation in 2013. No other medical comorbidities. So it's kind of the case.
Thank you, Dr. Kern, for providing this overview of this case. And I want to refer back to your question on how to best manage this patient with co-occurring opioid use disorder, sedative hypnotic use disorder, new seizures, and bipolar disorder. And so now I want to encourage our participants to ask questions or provide any insights about this case. You can unmute your microphone or drop those comments and questions into the chat.
If I kind of add one more thing, and essentially, like, what do we do for this patient with OUD that has persistent withdrawal symptoms, that's refusing buprenorphine and is on a pretty large dose of methadone?
I had one question about that specifically. What's her BMI?
I'm not sure, but she was probably, I mean, if I had to estimate, she's probably around 27.
Okay.
She wasn't obese or
Okay.
very thin.
I've just had a similar situation because fentanyl's so lipophilic that it's
Yeah.
taken me a lot longer. And so I was just curious. Some of my patients with a lot higher BMI have seen this more often. And also, you probably said this, I'm sorry, but is she currently pregnant?
Yes, she's currently pregnant.
How far along is she?
She at the time was, I think, 8 or 9 weeks when she came into the
Okay,
hospital.
so super early. Okay.
Yeah.
Hey, Dr. Kern, this was amazing. The case is nice and complex. I do have to tell you, I trained at UT Southwestern. I work
hmm
with a team. Dr. Nancy Unisco.
Yeah, she works with me. Yeah.
Okay, great. And then Dr. Clark.
Kleinschmidt. Yes.
Yeah, awesome. So there's a few of those I worked with. So they're pretty impressive cases and very complex cases that we get there. It's not easy peasy, but
hmm
I wonder, is she ever willing to go back on Suboxone, or she's 100% convinced she's not going to go back on it?
She was 100%. She didn't want to go back on it, even though we tried to educate her. I mean, I suspected that maybe she had a benzo withdrawal seizure at the time versus a primary seizure disorder. And
Sure.
obviously, I don't think it was from, I mean, we tried to convince her it wasn't from the buprenorphine, but she was insistent that she didn't want to get back on it.
So, and you said she's on once a day dosing right now, and she continues to experience withdrawals?
Yeah, I mean, she's out of the hospital now. She left and went back to Austin, but she she
once daily dosing right now
My
and
stuff
still
is gonna be sorry. So what I was gonna mention is we had a similar patient who was pregnant in the clinic. And interestingly, with methadone, the metabolism can be very different for individuals,
Mhm.
especially, with pregnant females. So I mean she's on a very high dose, which is great, but which is also not great. It's a really high dose. But sometimes if we can split dose not just twice a day, but even 3 times a day, which is more consistent with chronic pain. But some people metabolize it so fast, which I didn't know until I went to a conference. And people in Canada actually do that a whole lot versus in the United States. They actually split dose 2 times to 3 times a day, and it does actually help a whole lot with their withdrawals versus only increasing the morning dose, because that can actually start to sedate um, the baby, if not as much as the patient, because she probably has a really high tolerance with all that she was using in the past. But I would be worried about the baby. She's been on this consistent dose. Probably the baby's healthy, is doing well. We don't want the baby to struggle in terms of the fetus to struggle in terms of the withdrawals, because that's probably going to be hurtful more than anything else. But I think split dosing would be very helpful, even if we can split dose 240, whatever milligrams that is. I think that might just be very helpful. But
Yes. So she was on split dosing for most of the hospital stay. She was on BID
twice a
dosing.
day.
Yeah, and then we transitioned her to single day because it's very difficult for us to
switching to
find.
dosing it twice a day can really help smooth out those peaks and
Oh,
troughs of methadone levels, especially during pregnancy. It can often reduce those lingering withdrawal symptoms without having to push the overall dose even higher. So that's a great strategy to consider and definitely worth discussing with her.
yeah, I mean that's what we're doing, but it's very difficult to find methadone clinics that will actually do BID dosing. We have finally worked out something with West Texas Center of Rehabilitation that's close to our hospital. They will actually do BID dosing now, but that was a struggle.
Solid approach there. Splitting the dose can definitely help even out those withdrawal
Something
symptoms and keep everything a bit more stable for most
something's
moms.
happening to my microphone.
Definitely a use.
No, I think it's for everybody.
Oh, okay. Yeah, I don't know if you could hear me, but yeah, we that's been the struggle, and then especially so what we've been doing is we usually start BID dosing, and then we continue that, and once we have an appointment for intake at WTCR is who we primarily use, then we kind of transition to single day dosing, but um, that's going to be the issue most of the time.
Well, I guess if she's willing to come to West Texas Lubbock, we do twice a day dosing, so we're more than happy to have her here.
Dr. Alog, we're having some problems with your audio. I don't know if you could mute your mic real quick and then unmute again.
Twice a day dosing, that can really help
Like
fine-tune.
we're having another source of audio in maybe your background as well. Thank you, Dr. Alog, for those recommendations. I do want to continue to allow others to share any recommendations, ask any questions that you have regarding this case, and how to appropriately treat this patient.
I had a question about the seizure workup. Because, are you able to hear me?
Yes.
Okay, good. Because I recently had a case. I'm working as an obstetrical hospitalist, and so it's not really my patient, but the patient on our service. And so she came in because she developed seizures and also drug addicted, and we had neurology involved, but we never really got the question answered, what may have triggered her seizures. So I was wondering, in this particular case, I mean, you also, the way you talked about it, you were suspecting it was caused by her withdrawal or her drug use, but is there any particular workup you would recommend?
Yeah, I mean, neurology saw her while in the hospital, and then she had an EEG, which did not show any signs of epileptic seizures, essentially. They were suspecting maybe it was a psychogenic non-epileptic seizures, but they still recommended her be on Keppra, and they signed off of the case.
Yeah, that's exactly how our case went. She was placed on Keppra. But then I'm wondering, if you don't really know what you're treating, and then somebody is already a polysubstance user, I mean, how does the Keppra interact? Does anybody have any experiences? So, I mean, like, could the Keppra actually cause more harm than benefit, is my question.
I mean, in my I don't know if someone else wants to comment. I mean, Keppra is basically the first line anti-epileptic drug that we use. I personally, as an emergency physician, I give it all the time. I don't think that would cause any harm. I mean, it's definitely not an addictive substance, and the only thing it can cause is some kind of mood, like dysphoria and things like that, from what sometimes people don't like. And they've made actually some new medications that are expensive. Sorry, my dog. That are actually more well tolerated than Keppra itself. But that's kind of my experience.
Thank you.
I'm sorry about the background. I had no idea what's going on with my background. I'm here in the car. But I wonder, are you worried about the interaction with methadone? Sorry, someone asked the question with Keppra. Were you worried about the
Yes,
interaction?
I asked that question. Yeah.
Okay. So interesting, there's no interaction of methadone with Keppra, which is levotiracetam. So I'm not worried about the interaction, which, it's sometimes we are, because methadone is a CYP2D6 inhibitor. So the levels can be, it can cause a level interaction, maybe make it go higher, or some other medication can inhibit the levels of methadone, make it higher, metabolize it like rifampin can. But with this medication, specifically Keppra, there's either two ways, there's no interaction. So not really worried about that, but that's a great question. I think we need to make sure there are no interactions. We're not missing on any of the interactions. So that's pretty safe.
Thank you.
And Dr. DeReese, that also sounds like an interesting case that could be brought to our ECHO community so that you could receive real-time feedback and recommendations on your case. Somebody from the Be Well team may reach out to you with that case presentation form so that you can present it at a later ECHO.
Okay.
Thank you.
I will try to gather, because again, if it's not really your patient, it's always more difficult to gather all the pieces, but I can give it a try, definitely.
Absolutely. Thank you. Dr. Ruiz, I want to give you the space to offer your comment.
Yeah, it's just, because she's pregnant, changing medication it really is not ideal if we don't know if the patient's going to respond to it or not. But one of the things that came up is we're not really sure if this is neurologic conversion disorder, where psychogenic seizure is the previous uh, name for it, like stress-induced seizure, basically, which is so common in our patients that have trauma or stress. So then I as a psychiatrist, I would almost wonder if she would benefit from lamotrigine, something that could have seizure protection and mood protection. But because she's pregnant, any change could rock the boat, sometimes in the right direction, sometimes in the wrong direction. So we're a little more hesitant to make drastic changes in pregnancy.
Thank you, Dr. Ruiz, for that insight. And we have just a few more minutes to allow our ECHO community to offer insights, recommendations, suggestions for this particular case, or ask any other questions.
If I could jump in, this is in my lane. I appreciate the discussion, but coming from the social work, behavioral health lane, I heard that she was recently kind of widowed. I mean, that her spouse or OD'd, and so this kind of overwhelming wave of grief came on. This idea of loneliness, not knowing if she has any support. I mean, this is just somebody that, in the best case scenario, would agree to go inpatient to allow for some of these medication shifts and for like the integration of grief support and counseling and just in-house support. It just feels really, there was really disconnected. There was something you said that I wrote down, that she's getting her meds from somewhere else. So this is somebody that, you know, even the medication distribution system is you know, not organized, and that's not due to the medical system. You know, this is a patient that, you know, has a lot of disorganization. So just if it was an ideal world, it would seem really safe to have this patient agree to go inpatient. And I don't know what she agreed to. I bet we all agree in some way.
So ultimately, we work with Nexus frequently. Ultimately, that was the plan. That was the plan, and she wanted to go, but she had a lot of behavioral problems. I think when she went there previously, and they didn't want her back, is what it came down to. And then her sister-in-law ended up driving up to Dallas to pick her up and bring her down to Austin with them. So at least she had like some family to help her out.
Yeah, I think we just all see pieces of our own patients in this patient, and this is incredibly layered. And so I can appreciate, you know, some of the hard stops, like when the solo treatment provider in town won't accept a patient back. That is a hard stop. So just wishing the best for her. I'm glad that all of us in this room and all of our squares are willing to keep saying, you know, what is next for you? Nobody's giving up.
Yeah, the hardest part for these pregnant women is just finding a place. And Nexus is fantastic. I mean, we send almost everyone to Nexus, and you know, we take their calls if they're sending somebody to the ER, and we work with them really well, and it's been going great. It's just some patients aren't the right fit for them.
Right. So some of the notes I wrote down is like, you know, if she was willing, you know, is there any digital link to keep her connected? You know, does she have a phone? Can she, I think somebody wrote the mama line, does she have the SAMHSA number? Does her sister have the SAMHSA number, just for that moment where that person agrees to say yes, or maybe you might even leave the state. You know, this happens in Tucson. I'm in Arizona. Tucson, we send people to Phoenix, sometimes California, sometimes New Mexico, because we just don't have the resource. So I was just thinking about the digital link, like, hey, we're happy that you're getting care in, I think you said Austin. You know, stay connected with us through SAMHSA or through this app. So anyway, just food for thought.
Thank you so much, Dr. Subrin, for that insight. And just to protect your time, we're going to go ahead and move on to our announcements. Dr. Kern, thank you for sharing this case with us. I hope you received lots of information, valuable feedback regarding your patient. And we'll continue to take comments and questions in the chat. Again, you can access that chat feature by clicking on the speech bubble icon in the Zoom toolbar. And in order to receive credit for today's session, participants must have an active account with the Texas Tech University Health Sciences Center Office of Accredited Interprofessional Continuing Medical Education Office. You can create an account by clicking on the link that's been provided in the chat or on the instructions on how to receive credit document that's been posted to the content tab on iEcho. Participants are eligible to receive up to 1 hour of credit based on the duration of your participation. For questions, specific questions about CME credits, please email or call the TTUHSC CME office. And let us know how we're doing by completing this evaluation. You can scan the QR code, which is on the screen right now, or you can click on the link that is in the chat. This evaluation will be available until 11:59 on November 6th. If you already have your account set up with the TTUHSC CME office, you can use the text in attendance feature with the code that is on the screen right now. That text code is only available until 11:59 p.m. today. Do you have a difficult case that you or your team have encountered? Let's tackle it together by bringing your challenging or complex case to the Maternal Health Echo. You'll get support from a team of experts and fellow providers. There's no need to prepare a formal presentation. We'll just provide you with a case form to fill out, which can assist you when you present your case. Please email us at cstat@uthscsa.edu to present a case. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics via our team of experts. To request technical assistance, please complete an online request form at cstat.uthscsa.edu/contact us, and we'll be pleased to help you. And now I'll pass this presentation over to Jen Erdege with PeriPan of Texas, who has a few final announcements for you.
Thank you, Brenda. So I'm just going to provide a brief overview of the Texas Perinatal Psychiatry Access Network, known as PeriPan, which is designed for clinicians who see pregnant and postpartum women. PeriPan was created to address the maternal mental health crisis. Mental health conditions are the most common complications of pregnancy and childbirth, affecting 1 in 5 perinatal women and ranking among the leading causes of pregnancy-related deaths. A lack of access to care and provider shortages further compound the problem, and PeriPan has 4 major components, as you can see on this slide. We will provide clinical guidance to help with a single patient case or enhance your mental health care in your practice as a whole. Next slide. PeriPan is anchored by 12 regional medical schools and health-related institutions across Texas, as you can see on the map. Signing up is easy, and you'll reach a mental health expert by phone and can consult with a reproductive psychiatrist within 30 minutes or at a callback time that you choose. Anyone in your office can call or text to start a consult or request. Each region does have their own unique texting number, which will be provided once you sign up, but you can call the number on the screen to enroll and we'll assist you. Next slide. And we'd love for you to join us for the PeriPan webinar series, which is held on the 3rd Tuesday of each month at noon in Central Time. This series runs through November, and then we'll kick off a brand new lineup of topics starting in January. We'll be sharing those topics soon, so just stay tuned. These sessions do complement the ECHO series, offering deeper insights into perinatal mental health. So on the screen, you'll see a list of the upcoming topics and dates. So be sure to register and stay informed, and we look forward to seeing you there. Next slide. And finally, this is the list of topics and dates for our upcoming lunchtime maternal mental health echoes, which are held on the 1st Tuesday of the month. We invite you to join us in future sessions to continue learning about these important topics and engage in meaningful discussions that support perinatal mental health. And I'll turn it back to you, Brenda. Thank you.
Thank you, Jen. Before we wrap up, I welcome Dr. Purvanshi Alag to provide our session summary and case recommendations. Dr. Alag.
Absolutely. So I guess I wanted to start off with the presentation that was given by Dr. Stephens. It was absolutely great. We all enjoyed it. I thoroughly enjoyed it, and I felt like the main takeaway for me was not just kind of screening the patients, but really kind of following up on the questions that we asked them. Even kind of small check-ins and helping would really help make environment very safe, where individuals can live, and not just females or pregnant, not pregnant, but just everyone in general is really important. So thank you so much for your presentation, Dr. Stephens. It was great. In terms of the case, it was spot on. It was a pretty complex case, which we did appreciate a whole lot. Insightful discussion. I think just to kind of summarize, was very important. That was already mentioned by Dr. Curran, that, some of the things really important were kind of treat the benzo withdrawal, which is very concerning, the most concerning. They can be deadly, right? So kind of treating those, taking care of the opioid use disorder treatment, considering the patient is pregnant. I mean, offering all the resources that we have. And of course, if she does have a diagnosis of bipolar, which sounds like I heard bipolar disorder moderate, we should treat that irrespective. Of course, respecting patient's autonomy and working with the patient is one of the key things we should always do. So I think this was great. It was very educational and informative. Thank you, Dr. Kern, once again for bringing up the case. And thanks, Dr. Stephen, once again for your great presentation.
Thank you for those closing remarks, Dr. Alag, and thank all of you for joining today's Mental Health Echo. We extend our appreciation to Dr. Jasmine Stephens and Dr. Joshua Kern for their parts in today's presentation as well. As a reminder, to earn CME credits, please complete the evaluation using the link that's been provided in the chat, and consider presenting a case or a scenario that you would like to share by emailing the CSTAT team. We look forward to seeing you at our next session on Tuesday, November 4th at 12 p.m. Central Standard Time. Have a great rest of your day, everyone. Bye-bye.